Dr. Srivastava is currently a stroke fellow at the Hamilton General Hospital and McMaster University. He will become a staff neurologist at Hamilton Health Sciences and McMaster University this November. He did his medical school, internal medicine, and neurology training at Delhi University in India. His research interests include acute stroke care, quality improvement in stroke healthcare delivery, and neurosonology. Welcome.
Thank you so much, Tina. And let me get started. Let me just make sure my slides are okay. Yes, good afternoon, everybody, whenever or wherever you're seeing these slides. So this is about posterior circulation stroke. So much of our morning's been about anterior circulation strokes and the classic ones, right? The fast positive signs and symptoms. But we'll step aside for a minute and talk about posterior circulation strokes. Strokes which don't often present in the usual manner with face, arm, or speech symptoms. And we'll try to figure out why we miss them at times and how can we pick them up more often, okay? So no disclosures, no conflicts of interest, except that I've been fooled by posterior circulation strokes myself multiple times. And that's why I have this keen interest in these special cases. So let me begin by just a standard case. This is a patient who's a 60-year-old lady. He has a history of hypertension, chronic kidney disease, oropharyngeal cancer, all treated now. She presented with acute onset pain at the back of the head for the last 24 hours, not getting relief with painkillers, and had severe imbalance and unsteadiness on walking. Began to eventually have severe dizziness, nausea, vomiting, no other symptoms, no visual symptoms, no double vision, no numbness or weakness of any legs, no droopiness of face, no speech deficit. However, because of her persistent pain and dizziness, she called 911. When the 911 crew came on scene, her blood pressures were super high, 200 over 110. No weakness that they could see, no visual field changes, which we come to towards the end of this talk, and no facial droop. So she was essentially fast negative. However, the crew was smart enough to examine her in more detail. They knew that something was going on. And when they examined her in more detail, they noticed ataxia, weakness, right-sided predominantly. And then something that we'll be talking again towards the end of this presentation, direction changing gaze evoked horizontal nystagmus. So some funny eye movements that they could see in the eye, but I'll come to what those were in more detail. Now, so this is a classical patient who would come to you, who would call 911 for help, who would have all these symptoms, dizziness, nausea, vomiting, imbalance and walking, but would be traditionally fast negative. So none of the classic stroke symptoms. And if you actually go on to see what happened to these patients, in ED, a plain scan already shows these hypodensities that you see at the back of the brain. This is the normal cerebellum, and these hypodensities that you see, these are her strokes, which had already formed because she was symptomatic for more than 24 hours. Better seen on the MRI. So on the MRI, this is again the cerebellum. The black areas are the normal tissue, and then this white parts are the diseased or the stroke that we can see on her scan. And then on CT angiography, two vessels at the back of her neck, which supply the back of the brain, known as the vertebral arteries, which should be somewhere here. We see that we aren't seeing them. So when we looked at her vessels, both her vertebral vessels supplying the back of the brain were blocked, and she'd already formed strokes. Unfortunate, because the patient wasn't aware that these symptoms could be a stroke, and patient did not call 911 early. And B, if they'd called, it might have been a tricky one to pick up as a stroke because she didn't have any of the classical stroke symptoms. Let's go to another patient. This is a 60-year-old gentleman. He had history of hypertension, coronary artery disease, and dyslipidemia. He developed sudden onset generalized weakness, diaphoresis, and episode of vomiting at home. His blood pressures, he immediately called 911. So he didn't waste any time. He knew something was wrong. When you arrived on scene, you saw that blood pressures were 140 over 90. His oxygen saturation was okay. He was pale and diaphoretic, but his ECG was normal. And again, he was another gentleman who was fast negative, no facial droop, no arm weakness, no slurring of speech, none of those classical stroke symptoms. But he was ongoing, still dizzy. He was unable to ambulate, and this prompted a more detailed exam from the EMS crew. And they noticed, again, his eyes having some strange movements, which I hope by the end of the talk, everybody is more familiar in recognizing what we call nystagmus. His eyes had both horizontal and vertical nystagmus. He had a field cut, so he couldn't see objects in his left field of vision. And then on ataxia testing, his finger, nose, finger, and heel, shin, knee were all abnormal on one side. So gross asymmetry on one side, all suggesting focality or stroke. And as a result of the alertness of the crew, patient came to the right hospital as a stroke activation. The CT did not show any hemorrhage because that's the one thing that we're looking to rule out before we give them the clot busting medication. And once the CT had ruled that out, we could give him TNK within 1.5 hours of symptom onset. And by day 3, he had essentially returned back to his baseline. NIHSS stroke scale that we use to gauge these symptoms was all back to normal. So he was back to 0 on day 3. So just because he was alert enough to call 911 at the right time, the 911 crew was alert enough to recognize these as a potential stroke syndrome. And because he got to the right place at the right time, he got the right medication, patient did really well. So that's my hope for today, that I'm able to bring awareness about this, that we have these posterior circulation strokes, which may not fit a classical box of stroke symptoms and still be very disabling and need the same level of urgency and care that we show for our classical anterior circulation strokes. So let me start now. Why do we do this every day? Now, I'll give you a story from one of my teachers. He is one of my most senior stroke teachers in the hospital. And he once told me that maybe 15 years back, when we didn't even have remote starting cars, he would get a call at night and his wife would get up and he would the wife would get up and start his car and get it warm while he was getting ready, changed, and be ready to come into the hospital. Now, we do this every day. Why? The reason is because time is brain. That's the only thing that drives us. So about 130 billion neurons in the brain. Every minute, 1.9 million of them die if they are ischemic or if they're suffering from a stroke. A single minute of ischemia ages your brain by 3 weeks, whereas if you let that ischemia get prolonged to about an hour, the brain ages by 3.5 years. Now just imagine if you're 70 and if by a single hour, your brain age increases by 4 years and you're 74 immediately, for another hour, your brain ages by 10 years. So that's a lot of damage to the brain, and for people who are elderly, every year counts, right? So that's the goal, to prevent those 1 million neurons dying per minute, to prevent that from happening. Now, 911 is the most important emergency crew that we have, and that's the most important system that we have to diagnose these strokes in the field, get them to the hospital in time, and get them the approved therapy. 70% of strokes will be encountered by EMS, and it's now well proven in literature, pre-hospital notification reduces door to CT and door to needle time, and that eventually improves outcomes for all stroke patients. It is true, though, that functional outcomes for posterior circulation stroke patients is much worse than anterior circulation strokes. And this could be for a variety of reasons. There's some delay in recognition by the patient, there's delay in recognition in the field, and posterior circulation, which supplies the back of the brain, is where all your crucial centers lie in a very, very narrow space. So a lot of very crucial, vital centers of the brain are in that small area. So even small damages to this part of the brain can cause a lot of damage. So unfortunately, functional outcomes for the posterior circulation stroke patients are not as great as their anterior circulation counterparts. However, the caveat is if you're treating them with thrombolysis, so the clot busting medication, or thrombectomy, wherein we go in physically and pull the clot out through a procedure, these patients will eventually go on to have better functional outcomes at 3 months than the anterior circulation stroke patients. So if we can salvage this part of the brain with quick immediate therapy, then these patients will actually eventually tend to do much better. So the problem is actually not with the disease, the problem is not with the therapy, the problem is with getting these patients to the needed therapy. And that's what our goal for this talk is, to help you identify, raise awareness, and get more of these patients in our treatment window. So to begin my talk, I'll just give you a brief outline of the anatomy of the posterior circulation. So this is just angiogram. So this is the traditional angiogram of the back of the brain. So you see, let me just use a pointer so that you can see better. Yes. So you see these arteries. These two arteries are known as the vertebrals. One of them is filling well here. The other was a little faint, so can be hypoplastic. That may be an anatomical variant. These two vessels, they originate somewhere around here, and then at the back of the neck, towards the base of the skull, they join together to form this one big vessel, which is known as the basilar artery. And it's just this one big vessel which supplies everything at the back of the brain. Okay. So that's one more problem of the posterior circulation stroke. So any clot, anything that will happen in any part will go up to this one big vessel, block this one big vessel, and cause extensive damage to so many vital centers of the brain. Now, we looked at what parts of the brain can get involved. So in posterior circulation stroke, there are large registries. So the most common posterior circulation stroke involve clots that travel all the way from the vertebral, go up all the way up to the basilar, and then are at the top of the basilar arteries, or the PCA, or the posterior cerebral arteries. So really distal end of the intracranial circulation, which supplies the occipital lobe, the thalami, and the midbrain and the upper part of the brain stem. So these are the most common strokes in the posterior circulation, about 41%. Next are the vertebral arteries before they join to form the basilar. So before that, they give off a couple of vessels known as the picas or the aicas, or the posterior inferior cerebellar arteries, which supply the real bottom of the brainstem, which is known as the medulla or back of the cerebellum. And then the intermediate group comes in the middle part. So just after the vertebrals form the basilar, and these supply all the perforators to the major part of pons in your brainstem. So those are about 16% of the stroke. And then you get a combination of all these hits. So you can have strokes in multiple territories in the posterior circulation, and they form about 25% of all your strokes. Now, coming on to what can be the various presentations of these strokes. So as I said, one vessel supplying all these parts, and all these parts will have different symptoms. So I did not want to give you a lot of details on to which part will have which symptoms, but let me just show you through multiple stroke MRIs which parts were involved and how myriad and how variable these presentations can be. So this part is known as the thalamus. We have two, so bilateral thalami. Thalamic strokes can cause just numbness on the opposite side of the body. So patients can present just with numbness, or thalamic strokes can have memory problems, confusion, depressed level of consciousness. So very, very strange and different presentations compared to your classical stroke syndromes. If you get both thalami knocked out from, say, a top of where the basilar artery terminates and goes on to supply both your thalami, if you get both the thalami knocked out, then these patients would be comatose. So thalamus is also your center of consciousness. So if you knock out the thalami, then you will not be able to regain consciousness. And so sudden onset, depressed level of consciousness, your first thing would be metabolic, drugs, overdose, stuff like that, but it can just be a stroke too. Next, we have an occipital lobe stroke. This is the center for vision. So this patient will not be, so this is on the left side of the brain. This patient will lose complete half of visual field on the right side of his visual field, as Rhonda would have explained to you about our visual fields. So no other symptoms, no weakness, no nothing, just loss of vision. But this loss of vision will be so disabling that the patient won't be able to drive. He may lose his livelihood. He will, usually the visual fields are also have poor regaining of function. So just vision field is lost and the patient is severely disabled for life. Coming down from the thalami, we have the upper part of the brainstem, which is known as the midbrain. So midbrain strokes can cause, of course, weakness on one side of the body, but they can also cause, like this tiny stroke can just cause a blown pupil in your eye. So if you say this is the right side of the midbrain, so right midbrain stroke can cause unilateral pupil fixed and dilated with loss of eye movement in that eye. And on the opposite side, the patient can be plegic. So you would think that patient's herniating, patient's having raised ICP, but no, it's nothing. It's actually a stroke which affected the nerve which supplies the eye. This is the pons going more down in the brainstem. Again, will have can present with weakness on one side, but can also present with an opposite sided facial droop. So usually when you have your anterior circulation strokes, you have face, arm, and leg involved on the same side. Here you can have facial droop on one side, arm and leg on the opposite side, which may confuse. And whenever you get these crossed symptoms, so if you have like in the previous case, a droopy eye, blown pupil, or fixed pupil on one side, weakness on the other, always think of a brainstem stroke. Similarly, face on one side, arm and leg on the opposite side, think of a posterior circulation stroke. So whenever you have cross symptoms, those are a big hallmark for posterior circulation strokes. Going further down in the brainstem, this tiny structure is the medulla, but is also the center for most of your vital centers, including your breathing and your cardiovascular centers. So very, very tiny strokes here can cause a lot of damage. And say this is known as a lateral medullary stroke. And lateral medullary strokes, they only cause numbness on the face on one side, numbness on the body on the other without any weakness, but they'll be so significantly disabling that you'll be severely ataxic, unable to walk. You will lose your speech. So your voice will, you want to say something, but you won't be able to get it out because it's hoarse or you can hardly phonate. You will have trouble swallowing. So you will lose your swallowing apparatus completely. So you are left with full strength in arms and legs, no facial droop, but inability to swallow, inability to speak, severe dizziness, ataxia, severe vertigo, just from this tiny stroke. And if it affects more medial structures, like this here, which is the medial part of medulla, you can, again, from this tiny stroke, you can have dense weakness on the opposite side of the body, sometimes involving tongue instead of face, because that's where the nerve for the tongue originates. So again, variable presentations. Strokes at the back of the brain, which involve the cerebellum, may just have dizziness and ataxia and nothing else. So like the patient's case that we saw initially, only vertigo, only dizziness, no slurring of speech, no arm, leg weakness, nothing of that sort. And these go on to have these large strokes. in the back of the brain, and they can be very disabling as well. And if you remember that angiogram that I showed you initially, so these were the vertebral arteries. They go on to form the basilar artery. And this basilar artery was supposed to terminate and form two posterior cerebral arteries, which would go on to join the anterior circulation here, unfortunately, through the communicating arteries. But here we see one big black hole. That's because the top of the basilar artery is gone and thrombosed. And this is the most dangerous kind of stroke, a stroke that we all fear, because this will knock out both your thalami, it'll knock out your midbrain, it'll knock out your center for consciousness, it'll make you completely comatose, and with very poor prognosis. So if you're not aware that sudden loss of consciousness could and persistent comatose state can be because of a stroke, this patient will be missed and might be delayed for therapy. And this is treatable. You do endovascular thrombectomy or give clot busting medications. You dissolve this clot, you restore the blood supply, and everything's treatable. So with that little bit of an introduction, where I wanted to just throw the various presentations of posterior circulation strokes out, wanted to tell you posterior circulation strokes are not uncommon. Now, granted that majority of blood supply to the brain goes to the front of the brain, that's about 80%. However, 20% of the brain's blood supply and 20% of the strokes that we see come to the back of the brain. So those are 1 in 5. So that's a big, big number that would classically not be fast positive. Not just that, we miss them because we aren't aware of that these non-classical symptoms can be stroke related, right? So the patient's not aware that these can be stroke related symptoms, so the patient doesn't alert 911 in time. And then, as you just saw, they can have so many vague or atypical presentations. This was from a meta-analysis of all the posterior circulation stroke registries, and they saw the most common symptoms were dizziness, vertigo, headache, nausea, vomiting, and depressed level of consciousness. These were the most common presentations of posterior circulation strokes, none of which you'd classically associate with anterior circulation strokes or classical strokes. And then there are various reasons for posterior circulation strokes. One of them are atypical causes like dissections. So dissections are basically small tear in blood vessels, and the vertebral arteries which supply the back of the brain are notoriously prone to getting these tears, getting these dissections. So, for example, if you've been to a chiropractor who manipulated your neck, or if you have the long drive and you were aggressively checking your blind spot or too aggressively or too excitedly, all of these things can cause tear in your blood vessels, and those can cause dissections in a 30-year-old or in a 40-year-old, in an age group where you wouldn't classically associate with stroke symptoms, right? So atypical cases and atypical causes and younger age of presentations. But as Rhonda previously said, if it looks like a stroke, if it feels like a stroke, it probably is a stroke. Don't think that this is too young a patient to have a stroke. Of course, if it's looking like a stroke, it probably is a stroke and should be treated with as seriousness till proven otherwise. Now, as I said, the fast mnemonic, if you just go by the face, arm, and speech, that's going to miss 50% of posterior circulation stroke. So we need to have more awareness both in patients as well as amongst the paramedic crew to pick up these strokes. And there was this study where they saw a lot of posterior circulation strokes, and they analyzed all the stroke symptoms that were not diagnosed in the field. And they found out that the most common symptoms that were actually from a stroke but were not related to a stroke, and stroke pathway was not alerted, were nausea, vomiting, dizziness, visual changes, visual impairment, field cuts, and altered mental status. And that's pretty obvious that those are not the classical ones that you associate with stroke. And because of all the reasons that I listed above, posterior circulation strokes unfortunately have proven to have prolonged door to CT time. Often the stroke pathway is not alerted, we are not pre-alerted, and so it's not till somebody in ER recognize it as a posterior circulation stroke. So the door to CT times are delayed, and sometimes the door to needle times, which is basically the time taken from the time the patient enters the hospital till we give the thrombolytic drug. The door to needle times are delayed as well. So there's data which shows posterior circulation strokes, the door to CT and door to needle times are much, much longer than the anterior circulation strokes because of all these reasons. This is a study in Austria in Europe, which suggested that about 100 people per year with posterior circulation strokes who are otherwise eligible for treatment were lost because of pre-hospital delays in activation and recognition. Now just imagine that in a small country like Austria and compare it to a densely populated part of the world like Southern Ontario, and just imagine how many patients we are losing for treatment because of these possible pre-hospital delays. And always remember that there's nothing, once a stroke is established, there's nothing that we can do. There's no other treatment option. So with that bit of background, let's now dive right into one of the most common symptoms of some of the common symptoms of posterior circulation strokes. And I try to remember these 5 Ds of posterior circulation strokes. So dizziness, diplopia or double vision, dysarthria or slurring of speech, dysphagia or swallowing abnormality. So remember the medullary stroke that we were talking about, sudden ability to swallow even your own saliva. And dystaxia, which is really ataxia, but just to make the mnemonic more funny and more interesting to remember, we have it as dystaxia, so an imbalance while walking. So dizziness, diplopia, dysarthria, dysphagia, and dystaxia. These are the 5 symptoms. Whenever you hear, your alarm bells should go off that am I dealing with a posterior circulation stroke? And for this purposes of this talk, I want to focus on this D, that is the dizziness part, because this is the most vague, most common presentation that everybody out there is complaining. If you have a fever, I'm dizzy. If you're weak, I'm dizzy. If you're tired, I'm dizzy. If you're having a stroke, I'm dizzy. If you're having an MI, I'm dizzy. So there are a lot of possible explanations of these dizziness. So we must dig into, whenever a patient says that I'm dizzy, what exactly is he meaning by dizziness? Is he having vertigo, which is a strong sense of motion or spinning? So he's feeling the room swirling around himself. Or if he's feeling disequilibrium, which is unsteady while walking. So the room's not spinning, but he's very unsteady. He's almost walking like a drunkard. Or if he's lightheaded, so he gets up from a sitting position and he suddenly becomes almost like a blackout. So if he's very woozy or just generally lightheaded and is feeling unwell. Or truly pre-syncopal, where he is about to lose consciousness, so he has tunneling of vision or is about to lose consciousness and is about to faint. And that's pre-syncope. So all of these symptoms, we need to ask the patient in more details. Are you having a true sense of spinning? Are you feeling unsteady? Or did you just change position? Did you stand up, or did you get up from lying down position and you felt as if you'll faint? Or were you going to faint? Were you having pre-syncopal symptoms, pale face, cold, clammy skin, that sudden feeling of about to faint? So you have to distinguish between what his dizzy symptoms are. Is it vertigo, disequilibrium, lightheadedness, or pre-syncope? The reason is that vertigo and disequilibrium we are really interested in can be stroke. Lightheadedness and pre-syncope, not usually stroke. Okay, and to decipher or dissect out that dizziness, we have the 3 T's. Okay, so the 3 T's are what is the dizziness together with, again, a mnemonic which sounds made up, but is more to help us remember. What are the associations of the dizziness? So what all features is the dizziness seen together with? Is there any hearing loss with dizziness? Sorry. Sudden onset hearing loss with dizziness, that's an alarm bell for stroke. Is there any headaches associated with dizziness? Is there any neck pain associated with dizziness? Is there any weakness, focal symptoms? Is there anything that is patients complaining apart from dizziness? Or is there chest pain? The patient might be having malignant arrhythmias after a heart attack, and that can make the patient dizzy. Is he having anything else? So that was together with the next important T is timing of dizziness. So how long is the dizziness lasting? Is this the first time he's been dizzy, or has he had multiple episodes, or he's been dizzy for weeks and months and it's just progressively getting worse? So if he's getting episodic dizziness, if he say had an episode of dizziness yesterday and an episode of dizziness today, that may be concerning for a TIA or TIA that happened yesterday and a TIA that happened today. But what if he's having these episodes of dizziness every few days or every few weeks in a month? That's probably not stroke. If he's having dizziness for the first time and in his life and it's just getting worse from his moment of onset, that's concerning. That's always the first really bad dizziness is always concerning. What we call an acute vestibular syndrome, so nausea, vomiting with dizziness for the first time presenting. And if it's stroke or some other etiology, eventually subsides in a few days. So that's an acute vestibular syndrome. Vis-a-vis a chronic form of dizziness. So he says, I've always been dizzy, but today is just a lot worse. So that's not very concerning for stroke. So that reassures us. So together with, or the associations, the timing of dizziness, and the third part that is important is the triggers of dizziness. So is he fine when he's in one particular position, but the dizziness worsens when he changes or turns in bed? So positional dizziness, that is usually inner ear related rather than stroke. Or if the dizziness started after a particular event like a trauma or took new medications like gentamicin or something. So if dizziness is triggered by an event, that is usually a not stroke. So if you get these little tidbits of information, what was the dizziness together with, what is the pattern of dizziness, were there any triggers, that really helps us shorten the differential, whether it's stroke or whether it's ear pathology or something else that you're doing. But the worst one, or the one that we are most concerned about, is this acute vestibular syndrome, which we'll be now talking on further. So just to recap, if you have any of these red flags with dizziness, that's very worrisome. So it's the first acute onset episode, never had dizziness in life, nausea, vomiting, dizzy for the first time, that's always a red flag. If the patient cannot walk anymore, even with help, so you do your exam, his arms and legs are doing okay, they're full strength, full grips, but he's still unable to walk, that's very concerning. If he has any acute hearing loss with dizziness, sudden onset hearing loss, that's very worrisome. There's new or unusual headache associated with dizziness. Remember, about 20% of all posterior circulation strokes are associated with headaches. If you have any new or unusual headaches, that's a red flag. Any patient who has a lot of vascular risk factors, so hypertension, diabetes, coronary artery disease, peripheral vascular disease, chronic smoker. So in somebody like that, even if I have a low suspicion, I would probably be more worried about a stroke rather than like an ear pathology for dizziness, because that more dangerous thing, the more thing that we need to treat in time is stroke. So I would err on the side of caution in those cases. Sorry, just a post-meal yawn. The other thing that I'm worried about when I'm talking about dizziness is if they have any unusual symptoms. So hiccups, persistent hiccups can be from strokes at the back of the brain in the medulla. So, or slurring of speech or any focal symptoms, any arm, leg weakness, facial droop, droopy eye, sensory numbness, crossed symptoms as we were talking about, face on one side, arm and leg on the other. face is numb on one, body is numb on the other side. So any of these unusual symptoms, if you have with dizziness, it'll raise a red flag in my mind. However, the idea is not to scare you into calling every dizziness as a stroke. If it's only dizziness without any of these red flags, without any of these other associated symptoms, so isolated dizziness is actually a good negative predictor of stroke. If you are only dizzy without any other symptoms, then your likelihood that you're having a stroke is about 70% lower than if you have any other neurological symptoms. So dizziness is really one of the lowest risk stroke symptoms that you have. However, the key is to not be fooled by any of these associated symptoms that you can have with dizziness and not to miss out on any of these other posterior circulation stroke symptoms. But there's only so much that the patient can tell you, right? That there's only so much that we can get on history. What can we do in examination to improve our examination skills for dizziness? So we always check for facial droop. We always check for arm and leg weakness. We always check for aphasia. What other things can we check for to make sure that the patient's not having a posterior circulation stroke? So for that, and there are three things that I want you to, if you have that suspicion, to examine in all your patients. One is Danish, and I'll come to it, hints, and then an eye exam. So in all your patients, if you've done with your usual fast assessment and you think that the patient's still something's off about the patient and you think there's still something going on and you're concerned that it might be a posterior circulation strokes, if you do these three things, I'm telling you, you're not going to miss any strokes in the field. So we begin with Danish, which is another acronym, but this one wasn't coined by me. This is an acronym that's well established in a book. The first D stands for dysdiadochokinesia, or inability to do rapid alternating movements. So you ask the patient to put one of his hands out front, and then with his other palm slap his palm in an alternating manner with the back of the hand or in the front of the hand in an alternating manner. So patient should be able to do this very quickly and very regularly unless he's having problems with his cerebellum. So if you look at this video, this patient's able to do it very smoothly. Look at this patient, he's able to do it pretty well too. But now you see how he's becoming more clumsy. He's not being able to maintain that rapid pattern. Movements aren't smooth. Every time you lose this smooth pattern of movements when you're doing this test, that's a red flag for a cerebellar or stroke at the back of the brain. So anytime you see a patient who's not able to, this should be, you can do it very fast. If you're not able to do this with like almost zero errors, then there's something wrong. Select red flag. Okay, so that's the D of the Danish, or dysdiadochokinesia. The next A is for ataxia, and we have different forms of ataxia. So we have gait ataxia, we have the finger nose-finger ataxia, and then we have the heel shin knee ataxia. Testing for different parts. The gait ataxia is testing your walking. The finger nose-finger test is testing ataxia in your upper extremity. The heel shin knee is testing ataxia in the lower extremity. For purposes of the Danish acronym, the A is really just for the gait ataxia, and we'll be checking finger, nose, and heel shin knee in separate parts of this exam. So if you see this gentleman, this is one of our very famous neurology professors. He's absolutely fine, but he does a very good demonstration of an ataxic gait. So when you ask these patients to walk, or if you ask these patients to walk with one toe in front of their other, they're very unsteady, they're rocking, they're to and froing, they have a very broad base to their gait. So walk like a drunkard with feet wide apart. And if you get them to do this kind of trying to walk in a line, they would not be able to. So that's the classical cerebellar or drunken gait of cerebellar ataxia, which should make you. So if a patient's not able to walk despite having no weakness, that's always a red flag in itself. The next N stands for nystagmus. So we've been talking about nystagmus since the beginning of this talk. So nystagmus is involuntary repetitive eye movements, usually seen and whenever you ask the patient to follow your finger either to one extreme, but sometimes can be seen in the primary gaze as well, and can be both horizontal rapid to and fro movements or vertical rapid to and fro movements. So let me just show you an example of what I'm talking about. So eye in primary gaze, nothing doing. But if you see, as soon as we started looking to the right, there's this rapid to and fro jerking movements that are happening to the eye. Now, the other thing that we want to look at is which direction of the eye is the rapid movement happening. So there will be a slow drift to one side and then a sudden rapid jerk to one side. So slow drift one, rapid jerk, and the rapid jerk is the direction of the nystagmus. I'll show you this video one more time. So nothing in the primary gaze, and then as they look to the right, so there's a sudden jerk to the right, and then a slow drift to the left, and then again sudden multiple jerks to the right. So that's a right beating nystagmus. And then if you look to the left, so here the nystagmus change direction. Now if you see to the left, it's beating towards the left. Okay. So this is nystagmus on field. Nystagmus is usually not good news, except if you have a unidirectional nystagmus. So the only nystagmus that is okay is if it's not changing direction. So if you look at the right, it's beating to the right. If you look to the left, it doesn't beat at all, or it's still beating to the right. That's unidirectional nystagmus, and that's the only good nystagmus. All other nystagmus, whether vertical or horizontal or direction changing. Direction changing in, by which we mean like it's beating to the right on right and beating to the left on left. So all these nystagmus are bad nystagmus and usually suggest of a central lesion. So dysdiadochokinesia, ataxia, nystagmus. Now for eye is intention tremor, but I also want you to take this step to do the finger, nose, finger. So intention tremor is basically when we do the finger, nose, finger, where you keep your finger out and you ask the patient to look at your finger and then your nose and then back to your finger and then his own nose, finger and nose. So this would usually be done very smoothly by a patient, but if not, then there can be two things. One, they're very clumsy and not able to hit the target, so they don't know where the finger is going. Or they may be able to hit the target, but as soon as they approach the target, they have a tremor. Hit the target, and then as soon as they approach the target, they have a tremor. So the I stands for intention tremor. So just see how as soon as it's approaching the finger starts vibrating. Otherwise, it's able to hit the finger correctly. But it's the same at the same step. You also check for is ataxia in the upper extremity, which is the finger, nose, finger test. So if you look at this patient and you have an object or your own finger, and you ask them to touch that and you see how they're searching for that object. So searching for that object and going to the nose, and then that's ataxia of the upper extremity. The S in Danish stands for slurred speech or staccato speech. Staccato is a very special type of slurred speech where you reach each word as if you're pausing in between. So you'll be reading a sentence as if you are getting a very slow teleprompter, okay? So if you look at this patient, So you see how that it's like he's reading each word in a gap. Oh, I'm sorry. I think the video or audio you were not able to hear. I'm sorry about that. But it's just like so very a scanning type of a speech. So in so the patient will take pauses between that. So that's a very classic slurred speech of the cerebellum. So that's the S of the Danish, and then the last part of the Danish exam is a heel to shin, which is testing for ataxia in the lower extremity. So you ask the patient to lift their heel, place it in on their opposite knee, and then drag it down a straight line on their shin. And they should normally be able to do it very smoothly, but just look at how clumsy this patient's heel to shin is. So they're unable to do it at all. Okay. And same on the opposite side. So see how clumsy they are on this, and they are unable to do a smooth action. So dysdiadochokinesia, ataxia, nystagmus, intention tremor and finger to nose, slurred or staccato speech, and heel to shin. If you do this, then you've done your full posterior circulation exam. Now, for one particular symptom or if examination finding, the moment you find nystagmus, and you want to make sure whether, so nystagmus can happen in any disorder of the ear or the brain. The one way to differentiate between whether this nystagmus is from the ear or whether it's from the brain is to do an Hints exam. Now, Hints is a complicated exam, but if you do it correctly, it can be more sensitive than even an MRI to pick up a posterior circulation stroke in an acute setting. So it's really the best exam that we have. And it consists of head impulse, nystagmus, and test of skew. So HINNTS. Okay. They added a plus to the Hints exam, which is now known as Hints Plus. And the plus that is for hearing losses, if there's any acute onset hearing loss. If you are sure that, so we'll be going about this in more detail, but if you have a benign pattern on the head impulse test, a benign pattern of nystagmus, no skew and no hearing loss, you can as confidently as you can with an MRI, you will be able to pick a stroke with that confidence. So when do you use a Hints exam? A Hints exam is used if you have an acute vestibular syndrome, so dizziness, nausea, vomiting, gait, ataxia, with nystagmus. So you did the Danish exam, you saw some nystagmus. It's for those patients. And of course, with no obvious signs of stroke. So if you have obvious deficit, there's no need to do a Hints exam. But if there's no obvious sign of stroke, that's when you want to use your Hints exam. If there's no nystagmus, there's no need to proceed with an Hints exam because then the criteria to do a Hints is not met. Okay. So the first part of this is a head impulse test. So if you see this, head impulse is where so you make sure that the patient has no neck trauma or head trauma. You're not suspecting any dissection, he's not complaining of any neck pains, and then you suddenly give a jerk to their head 30 degrees one way or the other. And then you look for what's happening to the eye movements. You ask them to keep focusing on your nose. So fixate their eyes to one point, and then you give a sudden jerk to one side. And you are looking for if there's any abnormal delayed catch-up movements of the eye. So we'll see this in slow-mo. So you give a sudden jerk, and then you see that eye movement that was, the eyes were kind of lost there for a bit and then suddenly came back. So that is known as an abnormal Hints or a Hints or a head impulse positive, abnormal head impulse or positive head impulse. And that, unfortunately, to make things more confusing, that is actually peripheral. That is not from a central cause. So if you see an abnormal head impulse, that's a good thing. If you did not see that catch-up saccade, if you did not see that catch-up eye movement, then that's a more dangerous thing, that can be central or that can be suggestive of a stroke. So look at it one more time. Sudden jerk, and then that catch-up saccade. Okay. Jerk, and that catch-up, slight catch-up saccade. On the right side, if you see, there's no catch-up saccade. So he's been able to fixate at your nose all throughout. Okay. So let's do one more example, and this would have been better in an interactive setting, but if you see this lady's head impulse, you see that catch-up saccade, that's a positive head impulse, which is a good thing, which means it's a peripheral cause, which means it's ear, not the brain. Okay. But there are a lot of problems with the head impulse. The patient must be awake and cooperative, like our two patients examples that we saw. If the patient's mentally impaired, if he's unable to fixate, if he's sedated, you cannot do this maneuver. If you're too gentle with the head thrust, it may be falsely negative. So again, it may alarm you for a stroke when it might just be peripheral. And of course, with any head trauma, neck trauma, unstable spine, neck pain concerning for dissection, or in fact, in patients with known severe carotid stenosis, you would probably not want to do a head impulse test. Okay. So if your head impulse was positive or abnormal, very good. You go on to the next step. So far things look benign. So far things look inner ear related. So next step is you re-examine the nystagmus and you see what it was. So here, this patient has a nystagmus beating to the left when she looks to the left, and has a nystagmus beating to the right when she looks to the right. That is the direction changing nystagmus, which is the one that we're always worried about. However, if you have a very good patient with a positive head impulse and a unidirectional nystagmus, so if you see his nystagmus is beating towards the left in his primary gaze as well. If you go to the right, it's either not beating or very slightly, if at all, beating towards the left. And then if you take them to the left gaze, it's beating very rapidly, but always to the left. It does not change direction with any side. If you have a unidirectional nystagmus, remember that is good. Whereas a bidirectional or a direction changing nystagmus, that's bad. If you have, say, let's look at one more example. So here, nystagmus towards the left, it's left beating. Yeah, again, better seen that towards the left, it's left beating. And then towards the right, it's right beating. So that's worrisome nystagmus or bad nystagmus or central nystagmus or direction changing nystagmus. Whereas, let's look at this gentleman's case. So left beating nystagmus on left gaze, right beating nystagmus on right gaze, dangerous nystagmus. Left beating nystagmus on left gaze, right beating nystagmus on right gaze. So dangerous nystagmus. And compare this with this gentleman. Some left beating nystagmus in the primary gaze. On the right, there's almost no nystagmus that you can see, or maybe some suggestion of a left beating nystagmus. And on the left side, the nystagmus is really florid and it's mainly beating towards the left. So unidirectional nystagmus, that's always good to see. That's always benign. That's always a good nystagmus. So two parts of your hints are done. Head impulse was positive or abnormal, or you saw the catch-up saccade. Your nystagmus was unidirectional, and so far so good. So then you go and look for test of skew. And test of skew is very simple. You ask them to focus on your nose or on your finger, and then you alternatively cover one eye and the other eye. And then you look for changes in fixation, and you see if there's any vertical movements happening with the fixation. So if you look at this video, you covered one eye. Now you see how this eye went a little up and this eye comes a little down every time you change. So this eye went up, this eye came a little down. So there's vertical misalignment of the eyes that becomes apparent when you close one eye. So as soon as you close one eye and you ask them to look, the eye either goes up or the eye goes down, and that's known as skew deviation of the eye. One more time. You see how the left eye is going up and this right eye is coming down. Left eye goes up, right eye comes down. Every time you change eyes, you have changing nystagmus. One more patient. Eye goes up. Eye goes up now. Eye comes down. Eye goes up. Eye comes down. Eye goes up. So that is test of skew for nystagmus. So remember, to call it a benign hint or a negative hint or a less dangerous hint, you should have all three things good. You should have abnormal or a positive head impulse. You should have a directional fixed horizontal nystagmus. You should not have any skew deviation. Any skew deviation is bad. You should not have any skew deviation. And if you're going by hints plus, you should not have any sudden onset acute hearing loss. If all of these criteria are met, then you have what is known as vestibular neuritis, and you can reassure and symptomatically treat the patient with vestibular rehabilitation therapy. However, if you have any one of these tests positive as well, so if you have either a negative head impulse, you could not see the catch-up saccade, or if you had a vertical nystagmus or a direction changing nystagmus or torsional nystagmus, or if you had any skew deviation, so one of the eyes would either go up or down, or if you had a sudden onset acute hearing loss. So anybody with an acute vestibular syndrome with any of these, you are worried and you treat a stroke unless proven otherwise, and you activate the stroke pathway. So that's the beauty of the HINS exam. It helps you delineate even better than an MRI, whether you're dealing with a dangerous case or a benign case. Unfortunately, I don't have time for cases, but my presentation will be with you guys, so you can always have a look at these cases later on. But I just want to go to the last part of my talk, which is the eye exam. So you've done a Danish, the dysdiadochokinesia, ataxia, nystagmus, intention tremor, staccato speech, and heel shin knee. You've done the head impulse, nystagmus, and test of skew plus no hearing loss. The last part that I want you to quickly do on the exam is Horner's, and you already do this. It's just to note it mentally. So Horner syndrome is when there's loss of sympathetic supply to the eyes, because of which one of the eyes will become smaller, so myotic as compared to the other pupil. One of the pupils will become smaller, myotic compared to the other pupil. And it may become a little droopy as well, and that's very common. It can be seen in both anterior and posterior circulation stroke, but in posterior circulation stroke, it's pretty classical. So you always make sure that when you're looking at a patient with stroke, if you notice that one of his pupils is smaller and that pupil has a droopy eye, then that's very big alarm bell for Horner, and that's usually a common sign of dissection or something going on in the back of the brain. Or you do a visual field exam and you see what the visual fields are. So very quickly look in all quadrants, check can they point to where they see the finger? You do it in all quadrants, and you make sure that the patient's able to point out in all quadrants and he has no field cut. Sometimes, however, the patient may not be fully cooperative to point out where he's seeing your moving finger. So in those cases, you can do a blink to threat exam, wherein you quickly move your hand in each quadrant and bring them in the peripheral vision suddenly, so that the reflex of the body is to close that eye if they have vision in that field. So a threat to blink is another quick sort of a trick that you can use to find out if the patients have any field deficits or not. So if you've checked their eyes properly, you've done a Hins, if you've done a Danish, there's almost zero chance that you're going to miss a posterior circulation stroke. But if you have obvious stroke signs, please, you don't need to do any of these in more detail. So that's what I wanted to talk to you guys about today. So posterior circulation stroke, just remember, it's not just face, arm, and speech, not just the fast. You have to see if the patient is dizzy, what are the together symptoms of dizziness, what are the timing of the dizziness, what were the triggers of the dizziness. You do a clinical exam and you can always pick up a posterior circulation stroke. Your alarm bell should be raised if you have an acute vestibular syndrome or a infrequent episodic vestibular syndrome, say a couple of episodes, not very frequent. If it's more than 5 or 10 times similar episode, that's very unlikely for stroke. Do not forget the Danish hints and the eye exam when you're examining for face, arm, and speech. Just do these in addition, and you'll be able to pick up a lot of strokes. If you have a patient with altered mental status, sudden onset, patient was doing fine, talking to his family, and suddenly became drowsy and unresponsive, you should have a low threshold for stroke suspicion to rule out basilar thrombosis. And always remember, time is brain. So the faster you bring them to us, the faster we can give them the needed therapy, and the faster their brains can be salvaged. With that, I just want to end this talk and remind you, so we always have the fast pathway, but if you add be fast to that, so watch for sudden loss of balance and check for sudden loss of vision, then those are the two things that if we add to our fast mnemonics, we'll pick up a lot more strokes and won't miss any of these usual ones. So I'll stop my screen sharing.